uh, of course, thank you for coming. So I hope you have your good breakfast. So we'll just have to uh, make this lecture more interactive if you like. But I want to not interrupt also because I have to catch a lecture from our convention. Okay, so today we will discuss the acute glomerulonephritis, and we will discuss on how to recognize it and how to initially manage it at your level of understanding. So you might read in advance in the book about the disease, so particularly the post-streptococcal glomerulonephritis chapter in Nelson's. Okay, so it's a very good discussion if we will start with the case because at your level you will going to be seeing a case and how are you going to go about it. So this is a case of a 10-year-old boy with a history of URTI around 2 weeks ago and then came to the hospital due to edema, hematuria, headache, and the blood pressure measurement was 140 over 100 millimeters mercury. So what could have happened to this boy? So what's the problem of this boy to start with? So those were the problems, no? So clearly the blood pressure, even if you look back on my lecture yesterday, this is clearly a high blood pressure. So now we go to the discussion on post-streptococcal glomerulonephritis so we can understand what's going on with this patient. So the PSAGN or the post-streptococcal acute glomerulonephritis is the most common type of acute GN. So acute GN is the general terminology, but when you talk about a specific streptococcal infection that leads to an acute glomerulonephritis, that is what we call the post-streptococcal glomerulonephritis, hence the code PSGN or PSEGN because it's an acute case. So this is also the most common form of post-infectious GN and the prototype of post-infectious GN because there are other GN that is not due to the infection like immune-mediated or other infectious mediated like HIV or hepatitis. They can also cause GN. And PSGN is really, really very common in the developing countries, especially in the Philippines. But the incidence in industrialized countries like in the US or in the UK and even in Canada and Australia, the cases are really very low because they have a wide early detection and of course a very good preventive measures, no, like vaccinations, information, or education among parents. Okay. However, in the developing countries, in our country, of course, it's very common. Actually, it occurs in even for older individuals, for at least 40 years old. So you can actually have, if you are not 40 years old right now, you can have acute GN. And according to the data of the Philippine Registry, the Philippine Pediatric Society, it's one of the most common disease that has been diagnosed among pediatrician or even physician. And the causative agent is Streptococcus. These are the Streptococcus group A, which assumed to be the only strain capable. However, there are other groups of Streptococci like the group C and even the Zooepidemicus. But it's not very common, but the more common are the group A, beta hemolytic strep. Therefore, this type organism has what we call nephrotogenic, meaning their antigens has a capability to infect or to invade the kidneys to cause an inflammation like the nephritis. Okay? Now, before, when I was a student, there were called M proteins, the antigens of PSGN. But right now, there are only two antigens that has been investigated, which has a potential cause of PSGN. And these are the nephritis-associated plasmin receptor, or the NAPLR, and the streptococcal pyogenic exotoxin B. So the nephritis or the NAPLR are from the host. And if you have the host, the receptor plus the streptococcal pyogenic exotoxin B from the organism, then you can develop PSGN. Okay, both of these antigens have capability to activate the alternate pathway of the complement system. So I don't need to discuss to you about the complement system. I'm sure that you have reviewed it from your immunology or even from the physiology. Now, what happened? There are theories that will lead to the deposition of these organisms or antigens into the glomerular basement membrane. So at first, there's what we call in situ immune complex formation, meaning there's a formation of antigen antibody complexes in the circulation, and it will be deposited into the glomerulus. And this, okay, will not work. And this will cause a direct complement activation by a streptococcal antigen in the glomeruli. So the normal glomerular tissues now will act as an autoantigen, and it will react on other circulating antibody form against streptococcal antigen. So it becomes a complicated now because first there's an antigen antibody. If you remember the structure of the antibody and there's antigen, it attaches. And then in the circulating, it will be deposited into the glomerular basement membrane. This deposition will lead also to activation of autoantigens or autoantibodies that will go against the streptococcal antigen. So it becomes a complex. That's why it causes what we call injury to the glomerular basement membrane. So that's why your patient will become when the glomerular basement membrane will damage. So there are so many things that can happen. If you remember my lecture every day, there's a what we call leakage of those cells and even proteins, probably small proteins like RBCs or even WBCs will leak out into the urine. So the characteristic of PSGN are as follows. It's actually more common in children than in adults. Surprisingly, it shows around 5 to 12 years old, but it goes beyond less than 5 and more than 12 years old, although it's very rare. Because if they appear at less than 5 or more than 12 years old, you will not think most of the time of PSG, and you will think of another cause of the glomerulonephritis. And also, it's more common in male. I don't have any idea about it, but I think that because the male probably has a stronger maker of antigen antibody, that's why they are actually more commonly seen in the male population. The severity can be asymptomatic, meaning your patient might have just edema and just running around, to a severe manifestation of acute renal failure. Usually the site of infection is the pharynx and the skin, but in the Philippines, they both can appear. Actually, most of the times, they have history of upper respiratory tract, and then when you look at the skin, there are so many skin lesions as well because we live in a tropical country. So what are the manifestations when you see a patient, when you recognize it? There are only 4 criteria that you are going to remember. There's presence of hematuria, there's presence of edema, hypertension, and oliguria. And when you look back at the history, there's 1 to 2 weeks history of upper respiratory tract infection that probably a cause of streptococcus. And when it comes from the skin infection, it's around 3 to 6 weeks after a pyoderma. Okay. Now, the complications of this condition that mostly the reason why they are referred to us is because of the hypertension, because of the complications of hypertension like encephalopathy and congestive heart failure. Now, the typical course of PSGN started with the latest latency period, which around 7 to 21 days. And then after the 7 to 10 days, these are the time that the patient becomes on the oliguric phase when they have a critical conditions. They are already on the overt manifestation of acute glomerulonephritis. They'll present with oliguria and azotemia because of the low GFR. There's fluid and salt retention. Hence, the patient becomes edema and hypertension. And in very severe form, they can present with renal failure, hypertensive encephalopathy. When they have seizures, they have hallucinations. Sometimes they become intubated because of this, and heart failure. However, at some point, when the patient has already recovered from the oliguric phase, here comes the diuretic phase when the patient becomes voids spontaneously, the hematuria will start to improve and the BP becomes normalizes. So at around second week or around second to third week from the onset of oliguric phase, the patient's general well-being improve. It's like it doesn't happen. There's no storm happen in his life. So that's how it is. Okay. Now, when we go back to the history and physical examination, we have to perform a varied, concise, and focused data gathering. But because if you get this particular patient in really critical condition, you have to have a very fast history taking, like the history of skin and respiratory tract infection. There's history of weight gain because of the edema. There's changes in the color of the urine and even the habits, the frequency, and of course the overt edema. On physical examination, you have to get the blood pressure and height percentile because if you remember, you can only get the normative. Remember the graph yesterday that I presented? You can only know what's the percentile of blood pressure of this patient when you say it's normal, when you say it's high blood pressure, and you also get the age and the height of the patient. And the evidence of fluid overload, like increased blood pressure, there is pulmonary congestion by increase in respiratory rate, and of course the presence of edema and weight gain. But remember that the diagnosis is possible even in the presence of normal or minimally abnormal urinary findings. In fact, there are children that I encountered that they only have abnormal urinalysis, like they have RBC of more than 50 per high power field, but they don't have a manifestation of edema or hypertension, and the patient is just like well child, but there's a history of some form of just nausea and vomiting just one time, or a fever for 2 days. It's just like that. So it can be minimal or it can be of overt sign when there is what we call an acute kidney injury. So the acute kidney injury is a severe form of kidney failure. So it has so many complications. It involves multi-organ dysfunction. Like it's not only the kidneys, but it involves the lungs, it involves the heart, even it involves the CNS. So that's why when they go into AKI, they have to be referred to a specialist or even critical specialist to manage those types of acute emergency situation. Okay, but there are other presentations that can happen. This was what they call the atypical types of PSGN when there are short latency. Instead of 2 weeks, it can be to 3 days or less than that. And there is no apparent infection. You just surprised now, why isn't there no history of infection? And here comes the acute manifestation of PSGN. Or there's edema and hypertension, but with normal urinary findings. So you have to justify how this happens. Or the proteinuria can be minimal, and or the proteinuria is severe, but there is only minimal microscopic hematuria. So this can happen, but It's very rare. So if it's like this, like you have the atypical type, then it's good that you will refer that to a specialist. Now remember again, if you recall the criteria for PSGN, it should be sudden onset in a previously well child with hematuria, edema, hypertension, and oliguria. And when you look back at the history, there is 1 to 2 weeks of pharyngeal infection and 3 to 6 weeks of pyoderma. Laboratory findings, commonly they will present with hematuria, that is the definition of which are more than or equal to 5 RBCs in a freshly centrifuged urine, and you will appreciate dysmorphic red cells and RBC cast. I think I have discussed this yesterday also, the difference between glomerular and extraglomerular. So in PSGN, it is a glomerular hematuria. The CBC, this might be there are other people that they will refer to us because of anemia. But remember, in PSGN, anemia is usually to hemodilution, that giving transfusion might risk the patient into aggravating the fluid overload. So that's why when the patient is in the oliguric phase, you have to give them diuretics, or you have to limit the fluids until the kidney will recover later on. And then the anemia will just improve on its own. Now, in acute kidney injury, when there is what we call significant anemia, meaning the anemia is so severe that it creates some form of abnormal respiratory rate, like less than 5 or less than 6. That's it's called already severe, but it's called less than 7. But really, I do not see less than 7, so I don't usually transfuse with PSGN. However, if you have severely anemic patients, there's a fast rising of creatinine. This is what we call the rapidly progressive glomerulonephritis, and this is now a medical emergency. Now, the blood chemistry is usually azotemia. So there's elevated BUN and elevated creatinine that will lead to the symptoms of uremia. So the azotemia is the laboratory abnormalities like the blood chemistry. But when you say uremia, this is already the manifestation of the abnormal BUN and elevated creatinine. Now, what about hyponatremia? It's also very common in PSGN, but again, like anemia, it is usually PSGN, and you don't need to correct this condition. But the hyponatremia will just resolve on its own during the diuretic phase, or when the kidneys have already recovered. The hyperkalemia is the manifestation of AKI. You have elevated creatinine and elevated BUN. There's a hyperkalemia there's a shifting of electrolytes from the intravascular into the extracellular fluid compartment. However, you can only manage this one if there is a really severe manifestation or complications of hyperkalemia, like patients with bradycardia, or there's a form of abnormal ECG findings. However, it is very toxic. The high potassium level is really toxic to the heart. So that's why you need to remove the potassium as soon as possible by increasing its secretion and limitation its intake. So usually in our practice, we give furosemide to facilitate the removal of potassium in the body. And of course, we decrease the diet. Okay. Now, there are other hyperkalemic regimen, like giving of beta-2 agonist nebulization, sodium bicarb, insulin glucose infusion, and exchange resin. Okay, so these are usually not for a long time, but only for the acute onset, because if you have already a normal potassium level, like less than 4.5, then you can already stop doing this hyperkalemic regimen. The calcium gluconate is not really to decrease the the potassium levels in the body, but it maintains the integrity of your heart because, as mentioned earlier, potassium is very toxic to the heart. If you remember giving potassium directly, like in lethal injection in the past, so they gave potassium, high potassium, and then it makes the heart uh, flutter and then stop. So just like that. So that's why we give calcium gluconate to maintain its cardiac muscle contraction. And what are the evidence of a streptococcal infection? So of course you have to get, aside from the CBC, the urinalysis, and the other laboratory tests, you have to have evidence that this condition is caused by streptococcal infection by getting the ASO titer and other enzymatic or other antibody titer that is available in our hospitals. Now, the most common are the ASO titer. It's very cheap. Most of the hospitals are available of ASO titers. So these are also the preferred tests when you think of pharyngitis related glomerulonephritis. It actually increases 80%. The ASO titer will increase 80% if you have a previous streptococcal infection. But it can blunt the level of ASO titer if the patient has been taking antibiotic before you started the treatment, or the streptolysin O binds to the lipids in the skin to prevent the ASO increase. So for skin or pyoderma-related acute glomerulonephritis, do not get ASO titer because you will get confused. Instead, you get the anti-DNSB antibody. It's more specific to pyoderma-related AGN. However, it's not available and it's very expensive. What about C3? I mentioned earlier in the etiology that the antigen antibody, the immune mediated etiology of PSGN can cause activation of the complement pathway. And this is the C3 level. The C3 is the only complement that we use because it's also available. Unlike the other like C50 or C4, it's not always available, and we only get it if we think of another diagnosis of lowering the C3 like the lupus or other immune-mediated diseases. Generally, but not universally low during the acute phase of illness. According to this data, it can low around 70 to 80%, but it normalizes from 8 to 12, from after 8 to 12 weeks. So that's why if you have C3 level, which have a low, if you have a low C3 level, and then after 12 weeks it does not go back to normal, then you think for another diagnosis, not the PSGN as the cause of your acute glomerulonephritis. But also the normal C3 level does not rule out EPSGN because there are other factors that can alter the C3. This is sure to, although it's not very common, but if you have C3 and you are not sure if this is PSGN, because sometimes there are other diseases that can lower the C3 level, or there are other conditions also that there's a PSGN but also increases the C3, so it's a complicated thing. So if you have a low C3 and the ASO titer is positive and the other laboratory test will say so, then you can commit that this is PSGN. But for me, I don't get the C3 and ASO anymore. I just get the CBC and the urinalysis and observe the patient because it's, number one, it's expensive laboratory, and if I know the course of this particular patient and just improve in a week time, then I don't need to get those. No? It's an additional cost for the patient. Now, when the C3 is persistently low, so this is what I mentioned earlier, that there is persistently low C3 means beyond the 12 weeks, it's an indication that you are dealing with another form of glomerulonephritis, and it's probably not PSGN. So how do we manage it? So we Initially, we do fluid challenge if the patient is polygoric and we think that we don't want to have the patient go into more fluid overload. So if you think back when you have the discussion yesterday of pre-renal, so if there is an oliguric, it can be a cause of dehydration or decreased flow to the kidneys, then we give fluid. However, if the patient is already, you are already giving the fluid and there's no urination, then you have to stop the fluid resuscitation and limit the fluid to the minimum amount that uh, he or she can take, like the giving of insensible water loss fluid only. Okay, so there's a computation for that. I will discuss that later on. So that's why you will limit the fluid first. For doing this, you have to uh, compute for this one, no, the BSA calculation. So how do we limit? For example, our patient, oh, it's not our patient, the IK 10 kilos man. So how are we going to limit it? So you compute for the TFR or the total fluid requirement in a day that is equal to the BSA times the insensible water loss. So what is insensible water loss? Meaning the loss that you lost from the GI, from the respiration, from the urination, if there's any. So that's why the computation of which is the you compute for the BSA times 400 to 500 ml per meter squared per day, or around 20 to 30 ml per kilogram per day. But if you give diuretics, the total fluid requirement should be BSA times 400 plus the urine output divided by 2. So how do you compute the BSA? So we use the Mosteller formula. So the BSA is equal to height in centimeters times weight in kilograms over 3,600 square root. That is how you compute for the BSA. Okay, and then the result of which you multiply it around 400 to 500 ml. For example, for our patient, the weight is 10 kilos and the height is 96 centimeters. So you compute it if this is right. Screenshot and then confirm it is right. Okay, so that we can move on. Okay? Henry, okay na? Okay. The next thing that you can do to remove the fluids is to give diuretics, and that the common diuretics that we use are furosemide. The mechanism of action of furosemide is it inhibits the sodium and potassium 2 chloride symporter in the loop of Henle. That's why it's called loop diuretics, if you remember. But specifically, it inhibits the sodium potassium 2 chloride symporter. Okay? So if you block this particular transporter or symporter, there's massive excretion of sodium. And we know that the sodium, the water follows. So you remove the fluid at the same time. You limit the salt around. Of course, we don't actually have limit like once in a day like that. But at least we give some form, we decrease the salt, the high salt intake, approximately to less than 2 grams per day. So if you eat one burger, it's more than 2 grams. So if you let the child eat the 1/4 pounder of the burger, then quota na siya for a day. And you cannot give salt anymore. So that's how you salt restrict. So the use of antibiotics for streptococcal infection have two thoughts. They will give antibiotics because they want to stop the spread of the streptococcal infection. However, remember that this is post-streptococcal, meaning the complication of the toxins that has been released from the streptococcus bacteria. So that even if you give antibiotics, sometimes it does not alter the course of the AGN. Okay? So most of the doctors that I know of, they give antibiotic if there is an active infection, like there's still cough or there's still skin lesions. But others, they don't do it anymore. It depends on your decision as a doctor whether you give the antibiotic or not. Ako, if the patient is okay, is running, I don't even admit the patient. I just give instruction to the parents and limit all those things, and then I will let them come back as soon as possible time, and then I will instruct the mother what are the signs that she needs to come back for complications of the condition. Okay. Now, the most severe form of glomerulonephritis is the rapidly progressive glomerulonephritis. This is characterized by a rapid decrease in the GFR for at least 50% for a short period of time, from few days to 3 months. It can go up to 3 months, So that's how unpredictable it is. It might be that you have AGN right now, and then later on, you will have rapidly progressive GN. Now, the main pathologic findings of this particular condition is what we call the crescent formation. So if you look at the right side, the lowermost side of the slide, is it right still in your screen? So this is a glomerulus, and the crescent there, when you the highlighted the highlighted color of the glomerulus that's enhanced by a picture, that is the glomerulus that has been shrink. So when you say the crescent, it's from the Bowman's capsule and then the outer side of this shrink glomerulus. That's why it's called a crescent formation, like a crescent moon. So it means that your glomerulus has shrink and these mga cellular cells has been leaked out into the Bowman space. Supposedly the Bowman space is clear. So now we go to AKI because RPGN presents with AKI. Can you see it? So there are stages of AKI and we use the P rifle. In the adults, it's rifle only, but in pediatrics, we have the P rifle. Actually, in neonates, there's also an N rifle, but that's another thing. So it has 5 stages: the risk, injury, failure, and then loss and ESRD. And it is based on the estimated creatinine clearance and the urine output of the patient. So the problem for the creatinine clearance, the creatinine level, if we don't have the creatinine level to start with, to say that it decreases to 25%, so wala kay baseline. However, if you do the urine output, then it's easier to understand. So if the urine output is less than 0.5 ml for more than 8 hours, then that is considered as risk. If it is more than 16 hours already, then that is injury. And failure if there is already less than 3 ml per kilo for more than 24 hours, or there's anuria for more than 12 hours. So that is failure. However, it becomes loss if the kidney function lasted for more than 4 weeks, and ESRD if the loss of function of the kidneys is more than 3 months. Okay. Now, what are the indications when do you perform dialysis, which is the job of the pediatric nephrologist? But at your level, if you will see this kind of patient in the future and you will co-manage them, then these are the indications of dialysis, so that you can also explain to the parents why this patient have to be dialyzed. If there is severe volume overload with evidence of hypertension and pulmonary edema, refractory to the medications like the diuresis, diuretic therapy, persistent or refractory hyperkalemia, severe metabolic acidosis that is unresponsive to medical management, and if there is already neurologic manifestations like seizure or hallucinations or neurologic symptoms or decreased level of sensorium. So if you review back, these are the typical course of PSGN. If it does not follow in this particular typical course, then that is considered as atypical. Okay? So now we go to the clinical course. So we mentioned earlier that the earlier manifestations of PSGN started with oliguria, which can happen in 2 weeks' time. The hypertension can last around 3 weeks. The gross hematuria is also the same with this hypertension. So that's why the patient will stay in the hospital at this time if there is still hypertension or there's hematuria. The low C3 level is up to 12 weeks, and the proteinuria can even go beyond 6 months or 6 months. Sorry, I got lost. What happened? Okay. And look at the microscopic hematuria, guys. After the gross hematuria in 3 weeks, it can have microscopic hematuria starting from the onset of the disease up to a year or even 1 to 2 years. So that's why when the patient will come back to us, the mother worries, Doc, why is it that my child has still hematuria? When will it disappear? So I told them it's a normal course of PSGN and there's nothing to worry because we are still at the normal course. Okay? So does this PSGN recur? No. There are so many studies that says it does recur, but it's a rare incidence. And actually, I have not encountered recurrence of PSGN, but I have seen some studies that says because of the continued exposure to the streptococcal antigens or streptococcal infection, that's why it becomes recurrent and even it becomes persistent. So that's why they can have sometimes earlier a severe form, and then the recurrent is the more severe form. Okay, but it's good that it's very rare. So the possible reasons of recurrence can be suppression response against nephrogenic strains due to an early antibiotic therapy. That's why we don't give antibiotic therapy immediately without any evidence that there's an infection, because it gives more harm than good to the patient. The absence of natural response against nephrogenic strain. So this is already a host problem, or the failure to exclude microbial agent through a digestive and respiratory tract through an IgA deficiency. So meaning it also the problem of the host that it fails to clear the toxins in the body. Okay. So what is the prognosis? It's very good. It's actually 90% full recovery without any residual kidney injury. And the mortality will become higher if the patient will come in severe form or in the AKI or in the RPGN form, the more severe one. So to summarize, it's very important to recognize cases, the typical course of PSGN. However, unusual cases can also be equally important. So our job as a physician is to assure that the patient receives proper and adequate treatment, avoid diagnostic delays. If you are not sure, you refer the patient immediately. Do not wait for the patient that will go into a severe manifestation before you refer, because that's always the problem. There are so many physicians that they think that they know already what happened, and they become surprised with something that is not that is not typical. Okay, so we avoid diagnostic delays, we prevent the misdiagnosis, and of course, if we have already a severe manifestation, we avoid adverse patient outcomes. So do no harm also. No? Now, for difficult presentation, they might exhibit atypical, but it is highly unusual. No? But usually, the more typical are the ones that we see in our clinical practice. That's why when you have a typical course, you refer the patient to the pediatric nephrologist, and most commonly when the pediatric nephrologist will see it, it will boil down into the cause. The pediatric nephrologist will go to the basic concept, performing the biopsy to know what really causes the kidney problem. PSGN is possible even in the presence of normal or minimal abnormal urinary findings. The mortality of hypertension is really due to the majority of the hypertension in children is due to renal disease, unlike what we know that In adult, the cardiac is the most common cause of hypertension, but in children, the renal diseases are the most common cause of hypertension. Be wary of the multiple fluid challenges because it might lead to more harm than good to your patient. Be strict about fluid and salt potassium intake. That's why when you refer to me, I am very uh, keen to know about the INO of the patient. Okay, so PSGN rarely recur, but a typical presentation can be also the reason why you have what we call misdiagnosis or delay in the diagnosis. So I think I will stop here. If you want to look at the video, you can actually see this YouTube video. And then you can ask questions, by the way, if you have. We still have around 15 minutes to uh, have the Q&A or the open forum. Hello?
Wala rin questions, Doc.
Ha? Wala rin question? Sure mo? Kanindot ba ni kasi ako questions? Did I make my discussion clear? Did I go very fast? And so on. Okay, so Henry, you take charge of the attendance, please. And then share na lang to the others that didn't come in. Okay? Thank you, everyone.
Thank you, Doc.
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 Thank you, Doc.